brief, fire, brief as she'd get longer shot. On the back, she's a front royal girl, and she has a twin sister. She works in MTV as well, right?
Correct. Wow.
So, they're always interchanging the names. But we're very fortunate to have her, and if you have any questions, please, don't hesitate to ask them.
Russell.
Yes.
Just real quick. Is there anybody that hasn't checked off the sign-in sheet? And if you're new, would you please put your name, address, phone number, and email on the back, please? Thank you very much. I see a number of familiar faces here today, and I'm calling my patients. Just for curiosity, if I've done your PFT before, raise your hand. Oh, actually, all three of these ladies right there, I've done their PFTs before. It's my pleasure to be here today. I've been doing pulmonary function tests. I'm in my 37th year. The way we do the test today is essentially the way we did it 37 years ago when I started. The big thing that changed was the advent of the computer. When I first started out in pulmonary function testing, we had huge sheets of graph paper when you finished, and it had lines and squiggles, and you sat down with several different types of rulers, and you measured angles, and then you took all the measurements and you put them into equations, and it took about 20 or 30 minutes after the patient left to actually get the numbers. You eyeballed everything kind of in this graph paper as you went along. The computer has changed all of that. It's far more accurate probably than our eyes and the graph paper were. Now when you do the test, the results are instantaneous, every maneuver that the patient does. The other thing that has changed that I've noticed in the 37 years that I've been doing PFTs is the population of the patients. When I first started, almost everybody we saw had primary lung disease, asthma, emphysema, bronchitis, restrictive diseases like IPF and pulmonary hypertension, sarcoidosis. Today, probably about half of the patients we do don't actually have lung disease, but they have the potential for having lung disease, and they need to be monitored. A lot of these people are cancer patients. They're either, or this lady here mentioned radiation damage to her lungs because she had radiation for breast cancer. A lot of chemotherapy drugs can cause changes in your lungs. There are a number of also cardiac drugs, especially that are used either for blood pressure or to control arrhythmias that can damage lungs. So a lot more people have PFTs today than just the people who have lung disease. To start my talk, I titled it Pulmonary Function Test, a Piece of the Puzzle. We're going to pretend today that this is your first visit with a pulmonologist, a doctor that specializes in treating patients with lung disease. When you first go to see the pulmonologist, he doesn't know you. He doesn't know exactly what your history is, how you came to be there. He's going to view you really as a puzzle, and he needs to put the pieces together to decide exactly what lung disease you have and how it's affecting you. The very first thing the pulmonologist is going to do is a detailed history. He's going to sit down and talk to you for about 30 or 40 minutes. He's going to ask you things about the current symptoms that you're experiencing, how they started, when they started, how they affect you, what have you done to try to make it better, what has worked, what didn't work. He's also going to do he's going to ask you a lot of questions about your previous medical history. What kind of diseases have you had? What kind of surgeries have you had? What kind of medicines do you currently take? He's going to ask you about what kind of work you did, or what kind of work you currently do. And in that work, were you exposed to any kind of hazardous chemicals or products that would have been hazardous to your breathing? He's going to ask you a lot about your family history. Are there certain diseases that, like the alpha-1 antitrypsin, that some of you are familiar with? Do you have a history of those kinds of diseases, or histories of asthma running in your family? He will ask you the medicines you take, or whether you take supplemental vitamins and food supplements that might play into your history, if you have any allergies to anything. But he should spend about 30 or 40 minutes talking to you before he does anything. The next thing he's going to do is a physical exam. And essentially, he'll be looking from the top of your head down to the bottom of your toes. He's going to look in your ears. He's going to look at your eyes. He's going to look at your throat. He's going to feel the glands in your throat. He's going to take out his stethoscope. He's going to listen to your breath sounds. He's going to listen to your heart. He's going to examine your abdomen to see if there's any swelling or any pressure in your belly that might be affecting your breathing. He's going to look at your nail beds, the color of your nails, and he's going to look at your legs and see what your circulation looks like and check the pulses in your feet. Looking for clues that will give him some idea about what's causing your symptoms. After he finishes his history and his physical, he should begin to have some idea about what's causing your problems. But he's probably going to need to look a little bit further. And looking further might include blood work, whether he's looking at alpha-1 antitrypsin, whether he's just looking to see if your hemoglobin is normal, what your white blood cell count. So he may order some blood work. He may also order some heart tests, because some people with breathing trouble don't actually have lung disease, they may have heart disease, or they may have a combination of both. So it may be that he'll order some heart tests, an echocardiogram, an EKG. He's also probably going to order some x-rays, anything from a standard chest x-ray to the more sophisticated CT scans, PET scans, MRIs. Again, trying to gather information that gives him a clearer picture about your lung function. And then the other test he's probably going to order is what we call pulmonary function test. And that's what I'm here to talk to you about today. Why does the doctor order pulmonary function tests? First of all, he wants to see if you're normal or not. And if you're not normal and you're abnormal, he wants to see to what degree you're abnormal. He's also going to use the pulmonary function test to follow the progression of your disease, especially for people like the pulmonary fibrosis, where you expect over a period of years to see some decline. He's going to be looking at those pulmonary function tests. And they can also be used to determine whether the course of therapy is actually working. For instance, you may be asthmatic, but you've not been on asthma medicines and not on a routine of asthma medicine. So he may put you on some different asthma medicines and wait about 6 or 8 weeks and then repeat the pulmonary function test. It may be that you need to be on steroids. They can sometimes have a dramatic improvement in lung function. So you may take a fairly high dose of steroids initially, and then as he tapers down, he may be following the pulmonary function test just to see whether the tests are getting better or whether there's been a decline. Also, pulmonary function tests are used to evaluate lung disease as it relates to disability. A number of you here today can attest to the fact that when lung function deteriorates to a certain point, you cannot, you just can't function in your job anymore. And these tests are used by the disability people to determine disability. This is called a polyphnograph. The common name for that is body box. It has gas tanks attached to one side. It has a computer attached to the other. Most of the tests are done with the door open. There is one test that's done with the door closed. With this machine, and this costs about $45,000 to $50,000 for one of these, you can do spirometry, excuse me, go back, which is represented here. We can do lung volumes. We can do diffusion, and another test that's not shown here, muscle pressure testing. The primary tests, like I said, spirometry, lung volumes, diffusion capacity. These are muscle pressures, inspiratory and expiratory. The first test we're going to talk about is spirometry. It's the most basic, and it's also the test that's performed the most frequently. In fact, spirometry now can be done with, if you have the software, off of a laptop computer. And today you're seeing more doctors' offices with capability of doing spirometry. Doctors' offices can't afford to buy that $45,000 to $50,000 machine and do all this pulmonary function testing, but many of them can afford a relatively $2,000, $3,000, $5,000 spirometer, and they have people trained in their offices to do spirometry. The word spirometry comes from two Greek words, spiro meaning to breathe, and meter that means measure. So we're going to measure breathing. The two primary numbers that you get from spirometry: forced vital capacity. And that's the maneuver most of you are familiar with. You start out breathing along nice and easy. The technician asks you to pull in a deep breath, and then the technician yells, and all of them yell. That's part of that's how you're trained. Blow! And right then you blow as hard as you can for as long as you can until you've gotten all of the air out of your lungs. And usually when you're absolutely empty, we'll ask you to pull back in a real deep breath at the end. These tests, as you know, if you've taken them before, are patient dependent. You have to do the work. The technician is merely there to encourage you, to try to get you to do your very best. But the actual patient has to do the work themselves. Forced vital capacity.